So LTAC hospitals are this tiny, tiny little microcosm of the Medicare population. And I think the last measurement we have is from MedPAC, and it's like fiscal year 2012 or 14 or something relatively recent. And it was only 118,000 patients, which is a tiny, tiny percentage of the number of patients that come through for post-acute care and acute care hospitals. But they accounted for like over $5 billion of cost. Yeah, so they're expensive because these patients are really super sick. And on one hand, we have the LTAC hospital itself, and they, of course, want to have their beds full. And so they're looking to be able to bring patients in. And on the other side, we have the folks who are paying for that care. And the way reimbursement is set up right now is that that same patient, if they're in a certain type of hospital, the short-term hospital, they get paid a lot less, usually. There's sometimes contracts and things come into play. But generally speaking, the patient in the short-term acute care hospital gets paid a lot less than that same patient who happens to be in an LTAC. So there's that huge motivator to get that patient to an LTAC. And there's very little evidence, unfortunately. So we are threading the needle with our guidelines. We have two. We have one for ventilator-dependent patients and who are coming to the LTAC to be weaned, and we have another one for other long-term medical needs. And it's a challenge to write every year. As I was just telling them in my meeting this morning that the more controversial a topic is, the longer our footnotes get. And we talk a lot. We offer as many papers as we can and evidence. And but the conversation today was actually very collegial and very interesting. And I think both payers and providers understood both the history, the regulatory market, and the way our guidelines can help bring those together.